Hello and welcome to Yodo. I'm Dr. Sarah Bone. Today is another video installment to provide information and insight into interactions with patients that have dementia. We have a few other videos on the channel related to dementia, and so you might review those if you're needing information that's not covered here, but there are more videos to come. There's just too much information with this topic. We just can't present it all in one video. Let's review a few basics today. Patients with cognitive impairment, regardless of the type of dementia, have some similarities across all dementias, yet each person is a little bit different in their symptoms and in their progression. Many factors can contribute to the various issues that these patients have. Sadly, for nearly every cause of dementia, there's no cure available, so it is a progressive illness. Concerns such as hunger, thirst, pain, and even the time of day can affect the cognition and mood of a patient. If the patient is tired or sad, needs to empty their bladder or bowels, it might affect their ability to interpret their surroundings and make their needs known. As we discussed in other videos about dementia, there are so many different types, and we're not going to discuss those different types here. Knowing the type can be helpful, particularly at the earlier stages, but it's not so important at later stages, except for predicting the trajectory and the progression and anticipating decline. And it's really not so important on the day-to-day basis when you're dealing with a patient that has cognitive impairment that is living in your home or in a facility. Today we're going to give some additional care tips for patients with dementia, and we're going to be talking about appetite, nutrition, dysphagia, and weight loss. When dealing with a patient that has cognitive impairment, remember that these individuals have been respected adults and leaders, managers, business owners, many served in the military. They were individuals with authority. They have been children, siblings, and parents. So it's important for us to be respectful and appropriate with our communication. Sure, they may have memory problems, but they still may have considerable memory that is intact. More importantly, they're human beings and we need to demonstrate compassion and understanding in our interactions with them. Let's sink our teeth into appetite and nutrition. Appetite and nutrition are issues that are really unfortunate norms for patients with cognitive impairment. They can develop very specific taste and texture preferences. These preferences can really be challenging to navigate. They can become rigid with their choice for taste and texture, and they can actually self-limit themselves and become really restricted with their diet, and their diet can become full of odd choices. Taste perversion for patients with dementia is common. Foods that they may have previously enjoyed or commonly eaten in the past, they may be something that no longer they'll even partake in. They don't enjoy it at all. They won't even accept it. They may say that the food no longer tastes correct. The food is bitter or salty, or they may just have a vague complaint that it no longer tastes right. It's just wrong now. Commonly, patients with cognitive impairment are going to continue to prefer sweets. These foods typically will remain true to their remembered flavor. Some patients with dementia are going to have an impaired sense of smell, and that may also relate to their appetite. Weight loss and difficulty with feeding are common, and it's a very common point of contention for families. Weight is followed closely in facilities as weight change is part of the MDS, the minimum data set, and that's a collection of information that is collected and reported to insurance companies, regulators, and Medicare. Most facilities are going to have a special part of their dining area that's for individuals that need assistance to eat. When patients see others eat, they're more likely to eat. Having a staff member that's designated to quietly, patiently, and slowly assist them with eating is the norm. The facilities are also going to offer foods that are visually appealing and in a smaller portion size. They'll always get more food if they want to continue to consume it, but not overloading that plate for that first time when they see it. Sometimes that's a real turnoff for patients. And when the facilities identify that a patient has a particular table mate that they like or they don't care for, or they like to be near a window or have certain music on, most facilities will try to accommodate that. We want to monitor the patient's preferences, and above all, we need to be flexible. We want to try to work within the constraints that the patient sets up. It can be more important to get some calories into the patient than necessarily focusing on what they're eating. Some days, it's really important to get some calories in them. Consider frozen Ensure if they really like ice cream. If they prefer pudding, there are multiple kinds of fortified pudding. You might think yogurt's got a very similar consistency, but many of them don't like that sour taste that's in a lot of yogurts. It's okay for the patient to have oatmeal 3 times a day. It may be reminiscent of their youth, and we can certainly put protein and minerals in that oatmeal to make it fortified. But many patients are going to prefer finger foods or soft foods as opposed to foods that they're going to have to do a lot of cutting or a lot of manipulating with their fork and knife. Keep in mind, patients with dementia are not very physically active, so they're not burning as many calories as they once were, and their calorie needs are going to be reduced. Again, getting calories in the patient may be more important than the calories that they do consume. As the disease progresses, it's as if the person's body knows that there is a disease process occurring and that things inside of the body are changing, and decline is going to occur naturally. So do prepare yourself mentally that this is common and the appetite is going to change, and appetite amount that they're going to want to consume is also going to be decreased. That doesn't mean not to try and not to look for foods that they like, but I advise for you to choose your battles. Mealtime should be fun, and it should be a time for the family to interact. Mealtime should not be battle time, but mealtime should be a time of peace. We must also allow for patient choice. We owe it to them to allow the respect to them that if they decline the offer of food, we don't force them to eat. The patients may have the ability to have a lot of memory left, even though some is impaired, and we need to respect their authority over their own bodies. There are a few types of dementia that can affect the autonomic nervous system and actually stimulate the appetite. The increase of appetite can result in increase in weight gain. And this type of effect is not common with dementia, but it can occur. The weight gain can be significant, and it can lead to a lot of other issues. Fall risk can go up, increase in fatigue, problems with shortness of breath, and it can certainly affect their sleep. Overall, keep in mind the appetite is altered, and for many patients, it's more childlike. Consider a toddler and their likes and dislikes and appetite. Some days they may be willing to try new things, and other days they're not willing to try things that they used to like. Some days they may eat with great enthusiasm, and other days they may not have much appetite at all. Color, texture, and possibly smell can change their appetite. And like I said, for some patients with dementia, their smell can be altered or significantly reduced. So with patients with dementia, we're sort of stuck in this unpredictable area of constant change versus constant routine. But for the most part, planning to eat at home or in a regular routine at a regular time at a typical setting at the table, and keeping that routine is going to be better. Patients with cognitive impairment thrive on routine, and also if you're eating at home and in that same routine, it's more adaptable if there is an issue. Change in routine can be very upsetting for someone with cognitive impairment, and taking a person out of that routine can sometimes trigger some pretty undesirable behaviors. So if you do change the routine, you might want to have extra hands and familiar faces that are available to help and provide that reassurance that the patient needs. There can be times when it's necessary to eat at a restaurant, and depending on the severity of cognitive impairment, the behaviors and preferences of the patient, you can make that work. But you have to do a little preparation. Carefully select the environment, the location, and consider how long it's going to take you to get from the home environment to that location. You also want to look at the foods that restaurant has available and how that's going to work with the patient's preferences. Familiar foods certainly are going to be better choices most times. Generally speaking, new foods at a new place in a new environment is going to be just too many changes for that patient. So check out your restaurant, see what they've got on the menu, check out what the environment is going to like, and you might even ask them if it's okay for you to bring something for that one person from the outside. So if they can't accommodate that patient's particular tastes that evening, that you do have something that you can give the person. Also, does the venue allow for an activity for the patient. If they need to step away from the table, is there a place where a family member could go with them and sit quietly, or you could take them for a walk? If all of that really seems overboard, the smallest thing that you should do is prepare your server once you get to the restaurant. Just give them either a small card that says that you've got a family member that has memory impairment, or maybe step aside and let them know. But if the server is aware that you've got somebody in the family that has a memory impairment, it can go a long way to making the evening more smooth. So let's talk a little bit about dysphagia. Whether it's the issues with native teeth or poorly fitting dentures, that can certainly impair their ability to want to eat and can also affect their food choices, also affect the amount that they're willing to intake. A routine dental evaluation can go a long way to making sure that the dentures are fitting properly and there aren't a lot of teeth issues that are interfering with their appetite, and certainly having an OT evaluation, because the occupational therapist can provide tips for the family as to oral care. Now, most facilities have OT that comes into the facility routinely, and most staff members have cared for many patients with cognitive impairment, so they're used to the type of oral care changes that come with somebody that has cognitive impairment. Another major contributor to appetite concern is dysphagia, the difficulty with the process of functional and safe swallow. As simple and natural as it may seem, the process to chew, bolus, and swallow food is actually pretty complicated to get it into the right place at the back of the tongue and make it go down the right direction. And even if it's just small drops of saliva going into the wrong place, it can cause that patient to have a lot of coughing, and it can cause aspiration. Aspiration is actually a process like pneumonia, but it's a chemical pneumonia. A chemical pneumonitis is actually an irritation of the lungs where a little bit of the food or fluids or saliva has gotten into the lungs and caused that to be irritated, and then is a setup for them to have pneumonia. Weight changes are very common for patients with cognitive impairment. Typically, weight loss is expected. Contributing to the weight loss is the decline of the patient's functional capacity, as well as their ability to ambulate. The patient is less active and has less muscle tissue, and this adds to the decline in the patient's weight. There can be multiple issues with feeding that result in that weight loss, the progressive and nutritional changes that are difficult to navigate, and definitely these will contribute to the patient's weight changes. As cognitive impairment advances and their memory declines, the weight is also going to be lost. And sadly, this is one of the hallmarks we look for with disease progression. There's not a great treatment for this because it's part of the disease process itself. It's a very common occurrence. Allowing for the patient to have as much independence to feed themselves as possible, use of finger foods, fun foods, things that are tasty, fresh, colorful, and bite-sized will really help that individual, help that patient want to eat. But they still may lose that weight despite all that effort. As I advised earlier, choose your battles. As with a toddler, offering foods that are appealing and eating with others will encourage them to want to eat. And we see that success at most facilities because they have the feeder tables. Make provisions as much as possible to allow the patients to feed themselves. In a person with advanced dementia, we certainly want them to have adequate caloric intake and keep up with their fluids. But at some point in time, quality of life takes on a larger role, and it can be necessary to allow them to have more latitude and less rigid nutritional expectations. Yes, nutrition is important, but mealtime should be a fun event and not dreaded. With disease progression, declining weight and appetite, another common occurrence is the increasing weakness that can be noticed. There are many reasons for weakness that comes with advancing dementia, so it's not a simple fix. Many times, families innocently believe that if the patient will just exercise, they'll be more active and have a larger appetite, and that weakness is not going to occur. Weakness that occurs naturally from the disease progression typically cannot be reversed. It really takes a lot of effort to even maintain where they are. Once again, we have to remember that we're mortal and we do wear out. Your car is made out of metal and it still wears out. Your car or an appliance has parts that can be replaced, but that's not the case for us. We're mammals, and like other living mammals, we have a finite lifespan. We want to work with the patient to encourage them and to assist them with independence, but we need to have realistic expectations and not be unreasonable taskmasters for their exercise and to encourage the loved one and not demand from our loved one. We have to temper our expectations, and we need to be considerate of the patient. Get the patient to participate in activities that they can enjoy and they can be safe. That's key. It's important to have an activity that the patient is willing to participate with, and walking is probably one of the first things that comes to mind. Nature walks are certainly more fun than being on a treadmill, and they can even be more safe than a treadmill that's just going to march along at one particular speed and not allow you to pause. But we need to be mindful of the ability and the stamina of the patient. If the patient might fatigue or become weak and need to sit and rest, we don't want to be halfway around the block and there's no place to sit down. So if they have a walker or a wheelchair, you might follow along behind with that. Or if their walker is one that has a seat, then they can easily turn around and sit down if they need to. The terrain should be without obstacle, and it should be a low trip hazard. Temperature should be favorable, as they might not be able to regulate their own temperature well, and they might get chilled or overheated easily. Toileting and fluids should be considered before the activity is started. And then as far as pain medications, I encourage people to not give pain meds prior to the walk, because if the ability to walk is impaired by pain, we want that person to be able to say, I've had enough and my knees or my back are hurting enough that I can't walk anymore. Because if we give them pain medication before, they may walk so much that the pain level is higher than what the pain medication can manage, and now nothing can ease their discomfort because we've walked through that. There are so many other activities. For patients that are still pretty mobile, you might consider dancing, gardening, bowling, fishing, and even shopping. Almost anything can be constituted as being an activity for somebody that's more of a frail elderly person. Things that we need to do every day. So consider the activities of daily living. Getting up from a chair, getting up off of the toilet, getting up off of the floor, bending to put on clothes or shoes, standing for periods of time, maybe to do the dishes or to brush teeth. All of these things can be daily activities that can help us stay mobile. For less mobile patients, regardless of the reason, consider chair activities, even chair dancing or fishing from a chair. But chair activities are targeted to one particular body area, typically if it's like an exercise class. Upper body activities, lower body activities, and sometimes you can coordinate those, but it's better if you've got a patient who's cognitively impaired and limited to a chair that you not combine too many moving body parts at the same time, but just modify many activities so that the patient can do them from a chair. When the time comes, even some of these activities can be done when the patient is in bed, but they're going to need considerable assistance, because if the disease process has advanced that much that the patient has a bed-to-chair existence, sitting in a chair for an extended period of time, maybe just an hour, and they may not be able to participate in some of these activities, and they may need the family to assist them with range of motion. Facilities have restorative, but the patient may not be eligible for just range of motion by a physical therapist. Insurance companies have a lot of restrictions on what physical therapy and occupational therapy do. If the patient can't participate, they may no longer be eligible for that therapy. In the private home, the family members can learn how to assist and perform these activities to help the patient and help them get that exercise that they need, as well as provide some physical contact with that patient, and they'll feel less isolated. For patients in facilities, unless they are very much bedbound, just having the staff getting them up, assisting with getting them dressed and going, moving to the dining room, that's still activity for them. For some patients, struggling with the staff to get a bath or changing clothes, that can be exercise in and of itself. In summary, the dementia tips we talked about today have to do with appetite, weight, nutrition, and activity. Nutrition concerns are the norm for patients with cognitive impairment, as well as typically concerning for the family members and frustrating for the caregivers. Anticipating and having a planned intervention can help reduce everyone's stress. Plan for simple, easy, tasty meals in a comfortable environment, and stay with your routine as much as possible, but allow for flexibility, especially if the patient's having a bad day. Whether mealtime or exercise time, be respectful of the patient and their choices, Do your best to encourage the patient, go slow, and demonstrate patience with your patient. Join in again for more information and suggestions. If you've got a comment, please drop it in the comment box below, and we'll get back to you. Thank you for your time today. Bye now.